Good afternoon, everyone, and thank you so much for joining us. This is Debbie Plotnick. I'm Vice President for Mental Health and Systems Advocacy here at Mental Health America, and I'd like to welcome you to today's webinar, Medicaid Redesign and Expansion, asking the question, can we have one without the other? Today's webinar is the final one in the series for this calendar year that's sponsored by our Regional Policy Council, and we thank our Regional Policy Council sponsors for helping us this year: Activist Alkermes Anonymous, Lilly, Genentech, Janssen, Otsuka, Sanofi, and Takeda Lundbeck Alliance. Today's presenters represent a wide variety of expertise, including our very own Regional Policy Representative Mo Keller. I'm going to begin today by introducing the speakers and giving a little tiny overview of what you're about to hear. We're going to be talking about, we'll begin with North Carolina, a state that has not yet expanded Medicaid. We'll be taking a look at what they're doing to redesign and addressing their needs of meeting people and asking questions around that. We'll be looking at the state of Colorado, and Colorado is a state that not only has expanded Medicaid, but actually did so before they were required to do so under the Affordable Care Act. So Colorado presents some interesting information. We'll also be taking a look at New York State, a state that both expanded and recently has undergone a complete redesign. And I think that you'll find it very interesting to hear how recovery really frames their redesign. So I'm going to do a very brief introduction of all of our speakers, and then we'll be able to move right through all of their presentations. I'm going to begin with a little bit of housekeeping that we'll remind people a number of times about. If you have questions, please do type them into the chat box. I'll be compiling them and we'll ask them at the end of the presentation after all of our speakers have presented. And I'll also remind folks a number of times that today's webinar is being recorded, and the recording as well as the slides will be available on the Mental Health America website, and that's mentalhealthamerica.net. We'll have it up in about 2 weeks. Please bear with us, folks, as we have the Thanksgiving holiday in between, but we'll get it up there for you as soon as we possibly can. So let me begin by introducing our presenters in the order in which they will present. We'll begin with Kate McAllister, and Kate also is with our Regional Policy Council, and she's been with our MHA of Central Carolinas as the Assistant Director for 1 year. And in that role, she takes the lead in legislative tracking at the state and local levels. She has been tracking all kinds of bills on access to care, not the least being Medicaid reform, as well as prevention and integrated care. She also provides Advocacy 101 and 201 trainings for the constituents in, that might have to help me with this one, Kate, Nicholsburg and Carabas counties, and has rallied a local grassroots network of over 600 people. Prior to joining MHA of the Central Carolinas, Kate was the state legislative field representative for the American Psychiatric Association, APA. And while in her role at APA, she tracked and analyzed state legislation for all 50 states on issues pertaining to psychiatrists, psychiatric patients, and their families. She also provided advocacy training to APA members. Also joining us from North Carolina is Scott Branham, and he sits on the board of MHA of the Central Carolinas and is the current chair of the Advocacy and Public Policy Committee. This committee is charged with making policy recommendations that further the mission of MHA of the Central Carolinas and MHA's mission. Scott is an attorney at Garner Skelton, a Charlotte-based firm which partners with organizations of all kinds, from small startups to some of the region's largest and most recognizable businesses. Scott advises his clients, including medical providers, on the full range of everyday legal matters affecting their business. And prior to joining Gardner Skelton, Scott served as in-house counsel for for a Medicaid managed care company in Charlotte. We're happy to have him with us. Also speaking today is Mo Keller, and Mo is a member of our Regional Policy Council. Mo is the Vice President of Public Policy and Strategic Initiatives for Mental Health America of Colorado. Before she came to work with Mental Health America of Colorado, Mo served for 8 years in the Colorado House of Representatives and 8 years in the Colorado Senate. Little personal aside, I love when folks come up to her and say, "Hi, Senator." There, while in the legislature, she concentrated on legislation and policy for individuals who have mental health conditions and for individuals with developmental disabilities. Mo successfully sponsored mental health parity bills, legislation restricting the use of seclusion and restraint, and created the Children's Mental Health Treatment Act into state law. Prior to her work in the legislature, Mo was a special education teacher for deaf and hearing impaired children for 25 years. And we congratulate Mo for her marriage to Stephen Keller for 43 years, which is pretty fabulous. And Stephen and Mo have 2 adult children, 2 grown children. Also joining us from our MHA affiliate network is John Richter. And John's been the Director of Public Policy at the Mental Health Association in New York State since January of 2008. John joined MHA of New York State after spending over 20 years serving and advocating for elderly and people with disabilities. His career in human services began as a direct care worker in community residence for people with developmental disabilities. John has managed both community residences and intermediate care facilities, and has been also a behaviorist for a 14-bed ICF for adolescents with autism. So he spent an additional 13 years in long-term care policy with the New York Association of Homes and Services for the Aging, where he specialized in adult home, assisted living, and home care issues. John received a Bachelor of Arts degree in psychology from SUNY in Stony Brook. He received his master's in public administration from Rockefeller College of Public Affairs and Policy, also at SUNY, but at this time at the Albany campus, where he completed his internship in Medicaid rate setting for what was then the Division of Substance Abuse Services. John lives in Albany, New York, with his wife, Susan, and Susan is a practicing psychiatrist. We welcome all our speakers, and I'd like to turn things over to Kate to begin.
Thanks, Debbie. So I hope that everyone can hear me. So I'm just going to give a sort of 30,000-foot view of the state of the states in regard to Medicaid expansion and reform. So first, just a little bit of a background. I think, for those of you who don't know, under the ACA, Medicaid was broadened to become the foundation of coverage for Americans with incomes up to 138% of the federal poverty level. However, the Supreme Court ruling on the ACA effectively left that decision of whether or not to expand Medicaid up to the states. So this is just sort of a snapshot about the factors shaping Medicaid programs today. We know that Medicaid's history has been long and at times sordid tale, but 2014 to 2015 marks significant changes and transformations. So with the improving economy, if you agree that it is improving, which is a whole separate webinar, Medicaid programs across the country have, one, been implementing these changes included in the ACA, and two, they've been reforming and redesigning delivery and payment systems to help assure access, improve quality, and achieve budget predictability, which is really the focus of what our webinar is today. While nearly all, or effectively all, the states are addressing Medicaid expansion and or redesign in some fashion, even if that is a no, there's clearly no sort of one-size-fits-all approach. And that's sort of what we had determined when we were sort of looking at this topic overall. And when we were talking about this, Debbie reminded me of the old sort of punchy adage, if you've seen one state's Medicaid program, well, then you've seen one state's Medicaid program. So, what are those options out there and what's worked and why? And that's really what we want to take you through today. So this map shows a snapshot of the current status of Medicaid expansion in the U.S. It is as of November 2nd, 2015, so it's fairly up to date. You can see that 31 states, including D.C., have implemented expansion. 28 of those did so in 2014, so we did see a little bit of slowdown. It says one under discussion, and that is Utah. However, Utah lawmakers did oppose the Utah Access Plus, which is the most recent expansion plan of theirs, in October 2015, so just about a month ago. But I guess the rumor is that another plan may be in the works for 2016. And 19 states are not expanding at this time. So I think it's fair to note in terms of Wisconsin, although they did not adopt expansion, they do cover adults up to 100% of the federal poverty level. So in terms of delivery system activity, we've seen sort of a myriad of options for these delivery systems in Medicaid. But then there are some similarities. So as of July of 2014, all states except for 3, which are Alaska, Connecticut, and Wyoming, had in place some form of managed care, including risk-based comprehensive managed care organizations, or MCOs, primary care case management, PCCMs, programs, or both. Well over half of the states reported other delivery system reform initiatives underway. So for example, just over half of the states, so about 26, plan to implement or expand Medicaid health homes in FY 2015. And also nearly half of the states had patient-centered medical homes in place in FY 2013, and an additional 17 states in FY 2014 and 20 in FY 2015 were implementing or expanding those initiatives as well. And by 2015, 47 states took action that expanded the number of persons served in home and community-based services settings. So, there's just a myriad of different ways in which states have decided to expand or reform or both their Medicaid delivery systems. And with that, I will turn it over to Scott, who will take you through our example in North Carolina and tell you how we have, for lack of a better term, maybe struggled with our decision to expand.
Thanks, Kate. My name is Scott Branham, and I'm an attorney with Gardner Skelton in North Carolina. And I think Kate's comment is very accurate that we have struggled a little bit with expansion. We have not expanded here in North Carolina. And the reason for that is with regard to mental health services as well as other services such as physical services and primary care services, we are in the process of going through a significant overhaul in our delivery system, which I think, as we'll talk about, our governor is very focused on getting in place and having that delivery model work before we can get into expansion. So where I'd like to start is giving kind of a broad overview about what we're talking about in terms of residents in North Carolina served. There are 1.9 million residents in North Carolina that are currently served by Medicaid. And as you can see, if we do expand Medicaid, there will be an additional 800,000 and some change that will be covered under the expansion. And what we're doing with that is leaving, obviously, a significant amount of federal money on the table by not expanding just under $40 billion that we will not have access to. What we'll talk about next is kind of a little bit about why we're not expanding, and then we'll get into our current delivery system and where we're going. So our governor is Governor McCrory, and he tabled Medicaid expansion after the June 2015 Supreme Court decision. After that decision, he stated that he needed much more information in terms of what other states were doing before he could expand Medicaid. And more specifically, he really felt like our Medicaid system was broken in North Carolina, so he couldn't contemplate at the time adding more people to the Medicaid system until he felt like we had a sustainable Medicaid system. So our current system here in North Carolina has mental health, developmental disability, and substance abuse services operated under a managed care capitated system that are served through different providers and different managed care organizations than you would have for physical health or primary care services. So that's important as we go forward to keep in mind, because that system will remain in place under our current reform plan. What we have now is Medicaid consumers that are based in various counties are provided Medicaid services through a managed care company that oversees that county and potentially other counties. So we currently have 7 managed care organizations, or as they're often called, LMEs, that are receiving services through managed care, while if they need primary care or orthopedics or any other type of care, it's actually delivered through a different system. So with that in mind, our legislators settled into 2 camps regarding how they were going to reform Medicaid. And I will say that this took a significant amount of time. There was a Medicaid reform panel that was put in place that kind of, I shouldn't say disbanded, but ultimately didn't come up with a significant plan, and then it was kind of regenerated again. And our legislators fell into 2 camps as they started to work through this. One was a managed care model, and the other was an accountable care organization model that you see popping up, which is provider-led organizations where the providers have much more in the way of skin in the game in terms of how they manage and treat patients. If there are cost underruns within that organization, then the providers benefit. If there are cost overruns, then the providers are responsible for those cost overruns. We had two different proposed camps, and obviously we tried to find a compromise, which was a hybrid system that the governor signed into law on September 23rd of this year. So what this does is the long-term plan will be to combine all types of services received by Medicaid consumers, both physical health and mental health, developmental disability, and substance abuse under a privatized Medicaid managed care plan. So what we will have is contracts with 3 managed care companies that will compete across the state. We anticipate, and there's nothing in the current legislature that requires this, but we anticipate that these will be very large commercial plans such as Blue Cross Blue Shield or Aetna or United. Then at the local level, we will have 10 locally operated provider-led entities that will offer Medicaid managed care in 6 newly created regions within the state. Within those regions will be broken up into counties, and the counties must be contiguous counties, and there's nothing to prevent any of these provider-led entities from operating in multiple regions. Having said that, and kind of going back to the 3 large for-profit managed care companies, there's nothing in the current plan that says that those managed care companies can't be provider-led entities. We don't anticipate that will happen, but it is a possibility. So with regard to physical services, we're going to be moving away from a fee-for-services and moving into a capitated system. So the capitated system where the 3 large managed care companies or the provider-led entities will receive a specific number of dollars based upon the number of Medicaid consumers that we have within their particular area or within their particular region. Interestingly enough, even though we are moving towards that new plan and that new reform, under that new reform there will be a carve-out for the first 4 years where the mental health services will continue to operate under the same system that they are operating now. So we're going to be running 2 separate tracks for at least a 4-year period where the Medicaid reform will go through and operate on one path, but the mental health will continue to operate for another 4 years on its current path, but then it will ultimately be phased out. So what we could potentially have as this goes forward is some difficulty with the mental health providers and the mental health consumers trying to figure out where they're going to land and what they're going to do in terms of the delivery system. And we'll talk about that a little bit more, but I want to give you another little thought. related to the waiver and the waiver under which this is going to be operated. So North Carolina has to submit its waiver proposal to CMS by June of 2016, and the new waiver will be an 11-15 waiver. Once that is approved, we have 18 months to implement the new system. What we anticipate is that the federal government and CMS is going to give some pushback on our waiver due to our failure in expanding Medicaid. So we don't know exactly how CMS will respond, but there could be some difficulties with our implementing that waiver if CMS wants us to expand. So I think there could be some interesting and some challenges going forward on the mental health side depending on what happens. So if CMS all of a sudden requires that we expand Medicaid, we're going to have a significant influx of mental health consumers into the current reform package, which will continue like it is now for the next 4 years. And that could be difficult for some of the providers and some of those consumers. As that inflow of consumers is coming in, providers are going to be figuring out how they manage that influx, how they make sure that those consumers are getting the treatments that they need, managing the capitated system, managing the authorizations for care. But at the same time, while those consumers are needing those services, the providers are going to be worried about where they're going to fall in terms of working with a provider-led entity or a commercial plan moving forward to make sure that the providers can stay in business and provide those services to those consumers. So I think here in North Carolina, we are going to have some very significant challenges depending on how CMS responds to the waiver and then how we're going to implement mental health after the 4-year mark, where the managed care organizations that currently operate mental health in North Carolina are going to transition into either a consumer plan or into a provider-led entity plan. So please feel free to ask any questions, but having said that, I'm going to turn it over to the next speaker.
Mel, you're up.
Yep. All right. Thank you. Can you hear me all right?
We can hear you just fine. Thank you.
Super. Thank you. My part of the presentation is Medicaid reform efforts in Colorado. And as Debbie mentioned a little bit earlier, we actually here in Colorado expanded Medicaid to single adults prior to the Affordable Care Act option. The Hospital Association approached the legislature in 2008, 2009, asking to use a CMS-approved method of increasing Medicaid funding to the hospitals, and that was through the hospital provider fee. My understanding is most states use the provider fee now, but that's where the hospitals charge themselves a fee based on their bed size, meaning the number of beds they have, and then that money is matched by CMS, and then that money is returned to the hospitals. We found that in the first year of operation, we actually had to cap the single adults to 10% of poverty, the federal poverty level, because we did include mental health and substance use disorders as benefits, and that we had so many people that we could not pay for all of the people who were interested in being included, and so we had to cap that until more monies were accrued in following years. We also covered parents of children who are enrolled in Medicaid up to 100% of poverty for them, and then we expanded the CHIP, the Children's Health Insurance Plan, to 250% of the federal poverty level for the parents of those children, and we created the Disability Buy-In Program. So in 2015, we actually, through this method with the hospital provider fee, we actually accrued $689 million. That's just a phenomenal boon to us here in the state to be able to provide mental health and substance use disorder for individuals on Medicaid, single adults now also with the expansion. And then over the years and now we have aligned the provisions and benefits of the expansion population with our normal Medicaid population of folks who have been applying before, and those who are now going through the exchanges and are enrolling in Medicaid through the Affordable Care Act, so all of the benefits are the same. Our current delivery system here in Colorado is we have 5 behavioral health organizations who have the contracts with Medicaid to deliver mental health and substance use disorder treatments. And these organizations are actually a collection of mental health centers in regional areas of the state who come together to be able to bid for the contracts, and they do have those. Currently, we have 1,000,000, almost 200,000 individuals on our Medicaid caseload. All of them are eligible for behavioral health. We have 17 behavioral health centers throughout the state. I might mention, too, that about 2 years ago when the contracts were renewed, substance use disorders were aligned with mental health treatment in the contracts. So it is now that the mental health centers are now offering substance use disorders as well. And these contracts are a managed care contract in the carve-out model that many states have, including what North Carolina was just talking about. We spent $616 million on Medicaid behavioral health in the capitated payment format for this past year, including 2015. So we created the Accountable Care Collaborative in 2010. 3 of our state agencies have taken the lead: Healthcare Policy and Financing, which we refer to as our Medicaid, Department of Public Health and Environment, and the Department of Human Services. And as many of you may know, the whole point to the Accountable Care Collaboratives are to create primary care medical homes for every enrollee in Medicaid, to have data collection and analysis contractor, that is a special privatized contractor who collects all the data that we're hoping to have, and to be able to make better informed decisions on how to reduce costs, and then care coordination and support. And we call these RICOs. They are regional. There are 7 of them throughout the state, and they are the arm that we contract with. This was created by the Office of Medicaid, and they are, however, contracted with private agencies to be the coordinator to make sure that the billing is done, the technology is provided, that the care coordination is underway, et cetera. So I mentioned cost savings is, by changing the emergency rooms is a big feature. Treating the whole person in order to better enable the integration of mental health and physical health care. Building networks of providers who will eventually be receiving payment based on their whole health outcomes as opposed to fee-for-service, which will be going away, and providing more prevention and early intervention treatments. So enrolling Medicaid members into a medical home is that first piece that I mentioned. The medical home is the primary care provider, and most, if not all, of the mental health centers now in our state are medical homes for those individuals who are using the mental health center as their primary care. And so they are all offering some physical care in the mental health centers right now. And we will be beginning, and I'll talk about it in a moment, the second round of the Affordable Care Collaborative. This schematic I got from Medicaid here in Colorado, and it gives you a little bit of a clearer picture of what we're talking about. If we have the medical home, it incorporates behavioral health, the specialty care, hospital care, and community services. And by that we're talking about supports in community, peer supports, sometimes transportation. Hopefully we'll be able to get into support groups and housing. So the Regional Care Collaborative part of making all this work is to administer the whole Accountable Care Collaborative concept in an efficient manner. So they are the ones who are collecting, connecting the enrollee to all of the Medicaid providers, helping with the HIPAA compliance and the communication with each other for coordination of care, and trying to move forward in terms of helping the enrollee find community and social services in the area, something that Medicaid traditionally has not necessarily paid for. Well, to make all of this really work in a smooth fashion, Colorado Healthcare Policy and Financing, the Medicaid administrator in our state, has decided to eliminate the carved-out model for Medicaid recipients. This means that the contracts, as they are going to be renewed in 2 years, are not going to be bid with the mental health centers directly. They will be bid to the RICOs as the organizing arm in the regions, who will probably subcontract to the mental health centers. But the whole point to getting rid of the carve-out waiver model is that it has proved to be unsatisfactory because they're based on a covered diagnosis. And that makes it much harder to provide prevention and early intervention for individuals. It also has been a major stumbling block and barrier in trying to deal with those families and individuals who have co-occurring disorders. And I personally, as I can say as a state senator, this was a major issue that I tried to resolve for a long time, that parents of children and adults, but particularly adult children, who are developmentally disabled but have a mental health condition, were constantly getting bounced back and forth between the developmental disability system and the mental health centers, all of whom have said the developmental disabilities was not the main diagnosis, therefore the mental health treatment could not be served there. Very frustrating situation. Also, we're moving in the direction of life events, and so being able to cover things such as grief counseling has not been offered, or transition out of foster care to adult or youth services to adult services. And so by eliminating the carve-out model, we believe that we will be able to have a much smoother transition and be able to use our dollars more effectively and in more preventative care than we have in the past. Now, subsequent, or at the same time, I should say, we also received some funding from the Center for Medicaid Medicare Services, National CMS, through the State Innovation Model called SIM. And the Affordable Care Act has a provision in it that encourages states to be innovators and to be incubators of new ideas, new networks, new ways of delivering services, new ways of creating partnerships to reduce costs, to improve population health, and to improve consumer satisfaction. And so at the same time that we're looking at Medicaid redesign, we are looking at and are very excited to have submitted an idea model, and we were awarded $65 million to be able to design this and move forward over the next 3 years. So we will be changing the reimbursement structure. We will be creating networks of providers, and the exciting thing is that we will be including peers in that network. We will be integrating care, and the whole point is to improve outcomes so that the payment structure will be an outcomes-based model. And we are now currently in the process of designing the bids that we hope will be going out in the spring, maybe February, to be able to get this concept at least started in small ways. And so this is the match, if you will, on how Medicaid is working with the state innovation model. So we want, by May, to have half of all of our primary care medical providers in the ACC to be validated as meeting the standards for enhanced payments. I'll talk about that in a minute. We want to have practices serving over 500,000 clients statewide, introducing new performance measures to facilitate the integration of care. Screening rates is a big focus. That is actually going to be one of the first bids or requests for proposals that are going out, is the screening for adolescent and adult depression, and investing in telehealth technology for the rural areas of our states. So the primary care indicators that I'm talking about in terms of the incentives that will be part of the payment reform are the 3 bullets here. On-site access to behavioral health care, not that you have an appointment elsewhere across town, but that everything is on-site within that network provider. That screening, the health screening, which is the first thing rolling out in February for adults and adolescents. And youngsters, and then procedures to address positive screens. So you have a positive screen, then the referral mechanism, or how to address that in whole health. Those are the ones that will be going out the door in February, I believe, is what we're hoping to have. So we also have Accountable Care Collaborative Part 2. I might mention that in the first round of the Accountable Care Collaborative over the last 3 years, it was 2013, 14, and now 15, we have actually netted a $40 million savings in Medicaid expenditures just by going through the first stage of the primary medical care home model and the building of networks. It was very successful, and now in the second round, we have something called the Opportunity Project, and the theme is middle class by middle age. We want to work together across the departments of the state as well as through Medicaid in the regional areas of the state to provide interventions at life stages, which would be early childhood screening, supports for families in the community and through schools and other areas, childhood and adolescent screening and early intervention and prevention, and then adulthood as we do now, and then seniors, of course, assisting seniors as they get older. So as we focus on upward mobility with our concept of middle class by middle age, we are hoping that as we align our services, we can support lower income persons through all of these life stages. And that's it.
Thanks, Mel. John,
yes.
You're up next, and your slides are loaded, so you can just advance them by the arrows on the bottom of the, just move to the bar, and you'll be able to advance them. If you need help, let me know.
Thank you, Debbie, and hello, everybody. I'm John Richter. I'm talking on behalf of the Mental Health Association in New York State, and I'm just going to share with you for a few minutes what we're doing to transition in the state from primarily a fee-for-service Medicaid system to a managed care system for behavioral health. And I just thought I'd start to give you an appreciation for what a task this is, sharing with you some of the size of the program, Medicaid program in New York, and how much we've expanded. We have increased enrollment in Medicaid by 80% between 2000 and 2012, which brings us to about 5 million New Yorkers covered in the Medicaid program. That makes us, in sheer numbers, about second only to California, who I believe has about 7.5 million Medicaid enrollees. But more telling, perhaps, is that as a percentage of our population, that's a quarter of our population in New York State is Medicaid enrolled. We are way out of line with other states with regard to spending per capita. We spend $1,352. That compares to the national average of $600 per capita. So we are more than double the per capita expenditure for Medicaid in our state. And then some points to kind of bear in mind that will help make our strategy a little bit more telling for you are these statistics, that 20% of individuals on Medicaid in New York utilize 80% of the funding. And then 40% of that 20%, 40% of that 20% have behavioral health conditions. And also, another figure dynamic is that 20% of people with psychiatric disabilities in public hospitals were readmitted within 30 days. So bear those stats in mind. It will help make our strategy a little bit more telling for you as we move forward here. Some more stats to just give you a feel for size. We spend over $7 billion in annual expenditures for mental health. So 25% for state Medicaid expenditures on mental health. And then some feel for the size of the program, the number of people we serve in our mental health system, and the number of licensed programs. So about half of our mental health system, our public mental health system, is financed by Medicaid, and then the other half by state aid, state dollars. So, a rhetorical question. Are we getting our $7 billion worth? And while there's plenty of innovative things going on in pockets around this state, there are still some really disturbing challenges. The first being, you see listed here, is one that's pretty universal, I think you can relate to, is that people with psychiatric disabilities die 25 years younger than the general population. But particular to New York is that we have a high concentration of people with psychiatric disabilities in prisons. We refer to Rikers Island, unfortunately, oftentimes as the largest de facto psychiatric hospital in the state. 33% of those individuals have a psychiatric disorder. And we also have a very high unemployment rate among people with psychiatric disabilities and a very low graduation rate for youth with severe emotional disorders. So we still have some really significant challenges. So our strategy to reform the Medicaid program for people with for behavioral health in New York is really twofold. It's one, just to improve the quality and a lifestyle for people by reforming, but also to bring costs into control. And that is what our current governor has been trying to do since he came into office 5 years ago with an $8 billion budget deficit, and particularly targeted Medicaid as a very big-ticket item to get under control. Past governors had frequently tried politically to trim the Medicaid program with very limited success, going back to even before, but in particular to George Pataki, who some of you may know. He's running for president, or CNN is polling at less than 1%. Maybe you don't know. But he would, and others had tried to trim our Medicaid budget on sort of across-the-board cuts, and which were generally fought back and not very successful. Our current governor has taken more of a strategic approach with a redesign team to look at Medicaid and more efficient ways to structure the program. We're heartened to, as mental health providers, that that strategy to move to managed care has a heavy emphasis on recovery services as an integral part of the transition to managed care. You know, we fought hard also for a transition period that would allow us to get up the learning curve in time as managed care, as we move to managed care, and also that we had a decent baseline of activity in the dynamics of hospital admissions and length of stay with people with psychiatric disabilities. So we kind of had a metric to start with to gauge against our success against. So where we are at timeline-wise, I might have got ahead of myself here. Recommendations. Let me get right to the timelines. So New York City has already begun its move to managed care. It started in October 2015, and the rest of the states, I should actually say July 2016, will come online, so that everyone in the public mental health system will qualify either for a mainstream managed care plan, or there will be 140,000 people to start with who will qualify for what we call a health recovery plans, or HARPS, not to be confused with Home Affordable Refinance Program, another type of HARP. But in the mainstream plan, we'll have 700,000 lives will be covered, and essentially what it'll do is it'll take existing mental health services, physical health, pharmacy benefits, inpatient, outpatient hospital, pretty much everything, clinical services, and then this list of acronyms down here, that's assertive community treatment, personal recovery-oriented services, intensive psychiatric rehabilitation treatment, and continuing day treatment, and put it all under a capitated rate, so traditional managed care, if you will. What we consider to be, though, the game changer, and what we're really excited about is the HARPS. 140,000 people, as I said, will qualify, and those 140,000 will be based upon functional assessment, historical data, that sort of thing. It's an integrated product line for people with significant behavioral health issues. So think about that 20% that I spoke about earlier, the small percentage of people utilizing a high percentage of services and who are frequently in and out of the hospital. That's who we're trying to target. That's where we feel like there's a lot of savings and also a lot of just improvement. The kind of the heart and soul of HARPS is the authority that we have through 1915 I-waivered services. That we fought for a long time. Traditionally in the state, we have some experience with home and community-based services in our MRDD population, in long-term care, for example, and in children's mental health, but this will be a first for adult mental health, that will have this array of services, which should be, to most MHAs, will be very familiar. these HARP services, these waivered services that we will now be able to get paid for by Medicaid. These are things that MHAs in our state, and I'm sure in yours too, have been doing for many years. It's really the bread and butter of what they do. But at the same time, the majority of our 30 MHA affiliates are not currently Medicaid providers. So that needs to change if they want to get paid by Medicaid for the services they've been providing all along. And that's part of the challenge that we have as an association in support of our MHAs. Non-Medicaid providers, will work closely with health plans, and so they are getting to know health plans now, and that's part of their challenge as well, is getting familiar with health plans and having health plans get familiar with us and what we do and what our affiliates provide. So the great potential for HARPS in behavioral health in New York is really this idea of the focus on recovery services, that will now be an integral part of an individual's care plan. So all these different things that we've been doing for the years, funded primarily by state dollars, local assistance dollars, many of which will now be reimbursable under Medicaid as well. So we will have an additional funding of $600 million over the next 5 years for recovery services in particular. And then if I could just conclude with a few of the kind of recommendations that we're making to state officials and that we've been working on as advocates. So, for example, there's a widespread efforts to educate stakeholders about the changes. So it's been a steep learning curve. We've been at this for a couple of years now, and this has really been where a lot of the trepidation has been, and the challenge for the state officials as well as advocates to familiarize, particularly the non-Medicaid savvy providers, to familiarize them with this new world. So we still advocate for a strong safety net in place because there are plenty of people who sort of fall between the cracks that are still non-Medicaid eligible. But we also have concerns going into the future that the current way we fund some of these services through state dollars may potentially dry up, and as the state moves toward perhaps medicating them more so. So we need to make that transition. We advocate for metrics that impact quality of life. So in addition to the typical clinical types of metrics you can imagine that you would collect, we feel it's important to collect metrics on things like employment, education, housing, those other social determinants. We feel it's important to track. Also, we're real proponents of family engagement. We're really happy to see that it's included as one of the waivered services, and we will be advocating that and really trying to market that in an educational kind of way to plans. Just to wrap it up here, we also feel like there will be an ongoing, and there needs to be an ongoing role for state government as we kind of hand over this Medicaid program largely to managed care plans. So there needs to be a continued regulatory role of the state, and also a reinvestment of savings into community-based services, because at the same time we're doing all this with Medicaid, our state is downsizing many of its inpatient psychiatric beds. So it's very important, we feel, that there be ample funding available, taken partially from these savings, to invest in those community-based services. The workforce needs to be prepared, especially these hospital systems and managed care providers that aren't as familiar with behavioral health. So we feel like there's some literacy opportunity and things that we need to be doing with regard to getting them up the learning curve. And then finally, there's a role for us as advocates and other mental health advocates to have somewhat of an ombudsman type of a function in order to just sort of help assure that everybody's doing what they need to be doing, and that that we're vigilant in that there's quality care for everybody who we advocate for every day. So I'll leave it at that. I think that might finish the number of the speakers up, and we move into question and discussion, and I hand it back to Debbie.
Thank you, John, and thank you all for your presentations. I've collected a couple of questions along the way. Some are specific to our speakers, so let me, excuse me, let me ask those specific questions right away. A question for Scott is, sorry, I'm having trouble reading my own handwriting here. For the Medicaid expansion in North Carolina. Sorry, I need to go back and find that one. Pardon me on that. So what we want to look at is whether or not states need to have expansion beforehand. So we've heard some interesting things about carve-ins and carve-outs. It seems like managed care is something that is constant across the states. As Kate rightly pointed out, if you've seen one Medicaid plan, you've seen the other. You've seen one Medicaid plan. So it's very difficult to compare one to the other, but we do see, and we see from CMS, and we see in proposed regulations, that managed care is certainly going to become part of what we see happening now. It's something that CMS is encouraging. The other thing that CMS is encouraging is integration, so that we look at whole person and whole health. We have a specific question from Mo. Mo, can you take a second and talk about what the disability buy-in is, please?
Oh, sure, I'm sorry. So we had a situation where, and I'm sure everybody does, where individuals who have a disability cannot work over with any real substantial job without losing their Medicaid benefit, because they will be earning more than the federal poverty level allows for them to do. So it used to be, I think it's still $60,000 a year as income for someone who has a developmental disability to be able to work full-time and accrue that much income without losing their Medicaid benefit, and so they can purchase health insurance just like anyone else does, but they purchase it through Medicaid.
Thank you, Mel. I'm sorry, forgive me, I found my question for Scott. So Scott, the question is there managed care on the physical health side coming to North Carolina?
There will be. The whole plan that is going to occur, as you mentioned, is moving towards an integrated whole person system. So managed care going forward under the new reform will include physical health. The only thing that will not be included is dental. So going forward, when this whole reform gets in place and the whole waiver that's submitted to CMS will be a waiver related to physical health. The mental health, developmental disability, and substance abuse will continue as its own separate carve-out. It will not fall under the new reform for at least the next 4 years. That is the time period that was placed within the new legislative law that was just signed into law in September of 2015. We're not exactly sure why it was identified as a carve-out, and I say it being mental health services, developmental disability, and substance abuse services, other than I suspect that there was some lobbying going on to keep those services as a carve-out. So when after that 4-year period, when that system gets taken and put into the current reform, it will then fall under the new reform model that includes physical health, and it will all be integrated, again, focusing on more controlled outcomes, more whole health treatment as a means of reducing costs down the road for consumers and just generally reducing healthcare costs.
Thank you, Scott. A question for all the panelists. With respect to incarcerated individuals, what is your state doing if folks have Medicaid? Are they suspending? Are they putting people off the rolls? Are there plans in place for incarcerated individuals?
Well, this is Mo Keller with Colorado, and in 2010, the legislature passed a bill requiring Medicaid to seek a waiver to have suspension rather than revocation of Medicaid for when an individual was incarcerated. That's taken a little longer than we had hoped, but it is underway, and now it is suspension, not revocation. The other thing is that we have a very active group here in Colorado that's working with Medicaid to enroll inmates 1 or 2 months before they are to be paroled or to be released from prison, so that the Medicaid paperwork will be done and they will be eligible the day they walk out of the building.
Excellent, Mel. Are other states also putting in place what folks might need when they come out of being incarcerated?
Yeah, this is John in New York. If I'm not mistaken, we suspend, but that doesn't mean that the paperwork is always ready upon getting out. So we do understand that there's oftentimes a lag from the time when a person is released to the time when their Medicaid starts up again. You know, as an association, we've looked at trying to address that issue as well as things like presumptive eligibility. Even though most people who do go in, or a lot of people who do go in, have Medicaid already, some don't. So we've looked at presumptive eligibility, so that stuff would be in alignment when the person gets out. So that's it for New York.
Very good. I have a question that I want to throw to all of you. So hearing what you've heard about states doing managed care, the pluses and minuses of Carve in and Carve out, would any of this, would New York or Colorado like to offer the answer to the question to North Carolina? Is reform possible without expansion at this point? Sounds like a lot of their reforms are in line with some of your things. What are your opinions on that?
Well, this is Mo Keller with Colorado. As you can see, we started expansion before we actually got into extensive or well-detailed reform efforts. I'm cautious about the word reform because that means different things to different governors. And sometimes reform, and I've had this conversation with a couple of our affiliates in those states, the governor, when he says reform, what he wants to do is reduce the number of eligible people by lowering the federal poverty rate. So, however, you can have expansion without reform, but somewhere along the line, as I mentioned on the fee-for-service and the carve-out model, that carve-out model in and of itself, I think, is destined to change because it is not conducive to the integration of whole health as we are trying to envision it with the reforms of the Affordable Care Act. So I don't know if I answered the question, but I think you can do one without the other, but I think it's a great opportunity to be, and I would use redesign as a message, as an effort, and as an indicator that we can expand for those states that don't want to expand.
Yeah, and that's the terminology that we're using is redesign in New York. I do see there was a question up here that had to do with how much of our expansion was prior to and after ACA, and I believe it's about 20% expansion after ACA. So I mean, we've been expanding for a while, and so I guess the answer is, if I understand the question correctly, you know, we're doing both. We're redesigning while we expand. So I would imagine, you know, wouldn't it be less of a challenge to redesign if you weren't expanding at the same time?
An interesting perspective.
If I'm understanding the question correctly.
Well, the question is that given that Medicaid is so different in so many states, it sounds like what we're hearing is that we can have expansion before we have, we can have redesign before we have expansion. We can have expansion concurrently with redesign, and it sounds like North Carolina is working on redesign in, I think, what, if I may be so presumptuous here, what our speakers hope will be expansion. So again, in true federalist fashion, we have the states acting in many different ways that hopefully will work well for them and for their citizens. I'd like to take this opportunity to thank our presenters again, to thank Kate McAllister with MHA of the Central Carolinas, Scott Branham, who is a board member of MHA of the Central Carolinas, Mo Keller from our MHA in Colorado, and John Richter from MHA in New York State. We've had a couple of specific questions to New York State, and I'm going to email those directly to John because they're very, very technical, so perhaps he'll be able to answer them offline. At this moment, I'm not seeing any specific questions in general, and our hour is up. So once again, I'm going to thank all of the people who are on the call, remind them that all slides and audio recording of this webinar will be up on the Mental Health America website within a couple of weeks at mentalhealthamerica.net, and we look forward to you joining us for more webinars in our series. So again, thank you so much to all of our presenters and all of the people who called in and connected in to listen.
Thank you, Debbie.
Thank you.
Thank you.
You're welcome. Bye-bye, everybody.
Bye.